2025. Oh, I need, yeah, I guess. That helps, I guess. Let's save my voice. Okay, so today's agenda, first we're going to have approval of the minutes, which I'll ask for in a moment. They were sent out today, I believe, so I hope you had a chance to look at it. Then President Riley will be speaking, and after President Riley, Dr. Moro Salifu will speak to us, and then we'll have a presentation of proposed amendments to the bylaws, and then if we can all stand being here that long, we'll discuss the proposed candidates for election for this coming year. So without further ado, I'd like to ask for approval of the minutes. I need someone to make a motion. Thank you. Second? Thank you. All those opposed? I'm going opposed first. No one's opposed. Great. All in favor? Okay. We'll have a discussion later about that. He already has an email for me today, right? Yeah. Okay. So without further ado, Dr. Riley, please.
Thank you, Professor Noren. Thank you. Well, good afternoon, all. Good to see everybody. Finally, spring was taking hold here in New York City up until the last rainy period. If I looked a little tanned, I did just get back from Turks and Caicos. My wife and I celebrated our 32nd anniversary. So, if you've not been to Turks and Caicos, highly recommend it. It is amazing. So we had a great trip, so good to be back. Dr. Noren and I talk on a regular basis, and I want to salute his outstanding leadership. Alan, thank you for all you do for your faculty and staff colleagues here at Downstate. You really do a terrific job, and I enjoy our conversations and our work together. So thank you for all you do. Thank you. Let's give him a round. Thank you. Thank you. Well, I brought a little cheat sheet here. I wrote this out on the plane coming in last night because I said I knew I had to be here today with you. So the first thing, I want to salute everybody because of the Middle States review. We just had our Middle States reaffirmation of accreditation, as you know, last month. I think some of you were in the exit conference. We did fabulously well. So this is a tribute, again, to not me or the deans, but the faculty and the staff who really make this place run. We've received a lot of commendation from the site visit team about the curriculum, the level of engagement, the data collection, you know, the mission focus that we have here at Downstate. So again, I want to salute all of you and thank you for the great result. Now, technically, it's not official until they present it to the commission in June, but based on the exit conference I had with Dr. Imperato and the chair, we did quite well. And if you think about what we've done over the last, I guess, gosh, four or 5 years in terms of all the accreditations, we've done CEEF. We've done CEEF, right? Yeah, we did CEEF. Thank God that one's behind us, right? We've done CEEF, we've done LCME, and then we did Middle States, and then we've done the little ones in between in the School of Health Professions, the various programs. So it seems like we're always in an accreditation cycle. So again, I never take these for granted because if you will talk to your colleagues around the country, when you take one of these accreditation situations for granted, bad things happen. So again, thank you so much for all you did to make it Middle States a success. So let's pivot to sort of the tenor of the time in terms of what's going on in Washington. As you know, I spend a lot of time in Washington. I'm a member of the Medicare Payment Advisory Commission, so I'm in Washington every month just about. And colleagues, I can tell you, you know, going in and out of Washington since I was in college, I have never seen Washington as upside down as it is now, with the assaults on science, on common sense, the assault on the agencies that we care deeply about, particularly Health and Human Services, CDC, HRSA, EPA, NSF, you know, and the beat goes on. You know, the chancellor has been very good at keeping all 64 of us, meaning the 64 SUNY presidents, up to speed on what they are trying to figure out in terms at the SUNY system level about some of the impacts that could befall New York State and the SUNY system. And this is going to be in no particular order because I wrote this last night, as I said, coming in. The state budget, you know, the governor is, I think they're close to getting a state budget done. I think we're, what, 4 weeks late now? It's the longest it's taken since, I hear, 2010. But the governor was on CNN this morning. She said we're pretty close. She held out basically not so much for budget numbers, but because of the policy stuff she wanted in terms of discovery reform and the legal process. And what's the other thing, Alicia, she held out on? The discovery was the biggest thing because the defense, well, the criminal justice community thinks that the discovery rules, meaning the evidence rules when you arrest a criminal, have been so weakened that they can't keep some of these repeat offenders who keep doing the same criminal activity, you know, sort of where they need to be and not assaulting you and I and our families on the subways, et cetera. So she got that, but the budget numbers were pretty much laid to bed early. Now, the caveat is, as she has said, Alicia, help me out, New York gets about $90 billion in federal funds from Washington. And she has already told us, because we heard it at a SUNY president's meeting, that the state of New York cannot replace the loss of federal funding of the magnitude that we're bracing for. So the theme of this, and it's sort of the theme that I've been having, thoughts I've been having, is we're kind of bracing for impact. We don't know how bad the impact is going to be, but we know there's going to be some impact to SUNY and to us. So if you do the math, $90 billion, and that's sort of all in. Whatever federal dollar New York State gets in is included in that $90 billion. So needless to say, the state of New York can't make that up. So what then may happen, and I underscore may, is that the governor will call the legislature back into session, what, late August, early September? Depending upon when the president gets his big, beautiful bill, quote unquote, right? And by then, there'll be some clarity in terms of what the projected cut is to New York State, not just New York State, but all the states in the nation. That will then bring about a discussion between the House and the Senate and the governor about how deeply to cut, right, state government. We are looking at a couple scenarios. Just had a meeting today with Jamie, and we're meeting with Rich Miller. He's on jury duty, so he's not here today. But I've asked Rich to give us sort of a model if we get a cut of 10% of our state funding, and I'm not talking about the hospital yet, so I'm going to lay the hospital over here. This is just the university. So let me back up. We get about $55 million from SUNY as part of the base university budget. It's averaged around $55 million for like 10 years. I think one year it got up to 71, but that was really a fluke year where we got more state support. So we're going to have to look at if we take a hit in our $55 million base budget from SUNY, what effect would that have? And I can't tell you other than the fact it's the obvious. Hiring, we may have to slow down hiring or stop hiring. We'll have to freeze positions, you know, the typical maneuvers that I hate to, you know, implement, but if directed by the governor and the chancellor and the SUNY board, we'll have to. So we're going to model looking at various cut levels and see what the impact is. Alicia, do you want to, anything you want to say on that? Yeah, right. Yeah. So the other, right. So the other question that I have gotten, and you may have to help, is, well, Dr. Riley, the governor's already committed $750 million for the hospital. What happens to that? And I can tell you, I God's honest don't know. Right. 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 So, right, and that's the impact to the hospital. So like you said, now we're going to, so I just talked about the potential impact to the university. Now you then throw in the hospital. So now we're looking at the hospital situation. Sean Smith's here, who's the CFO and acting COO. Sean, help me out. We get about, how much DISH money we get? So DISH is the DISH proportionate share hospital funding that we get because we take care of a high percentage of lower income patients. The Trump administration may eliminate DISH, right? Or curtail it. So you just said 140 million, right? So that's 140 million we get to the hospital. It's usually 2 payments a year, as I recall, right, John? We depend on DISH, obviously, to pay the salaries of the physicians, nurses, techs, everybody in the hospital. The other part of it is, correct me if I'm wrong, Sean, I'm a pretty good listener when you tell me something. In addition to DISH, we get about $48 million in Medicaid patient revenue, correct? I'm sorry, Medicaid patient revenue. So you do 48 and 140, clearly, you know, at $200 million in Medicaid for the hospital. That's at risk, colleagues. That's at risk. That's what keeps me up at night on the hospital side. So again, we won't have any clarity until the president and the Congress come up with their reconciliation bill. What I will tell you is the House budget blueprint, the United States House of Representatives put out a budget blueprint about a month ago that's called for $880 billion worth of cuts to non-defense discretionary funding, meaning non-Pentagon, everything else, we got to cut 880. The Senate, the United States Senate, did their own reconciliation bill, which called for, I think, $2.3 billion in cuts, right, Alicia? And then what you do, you take out so you minus the 880 from 2.3, and then that's 1.7, 1.6-ish somewhere billion. So that's the amount of money they have to cut out of the federal budget if this sticks, So this is a headwind we've never had to deal with, at least in my career, cuts of this level. Sean, I don't think you've ever seen this in your career either, right? Yeah, no one has. So that's what's keeping us up at night, colleagues, is the unknown about what's going to happen to both the university, should the worst happen, and then the hospital. Let me stop there to see if there's any questions about that I can answer to the best of our ability, knowing that we kind of have limited, you know, direct or precise information. But like I said, if you ask me how do I summarize this, I'd say we're bracing for impact. Yes.
Eliminated staff, that eliminated replacement of staff, that wholesale eliminated programs, especially programs that are designed to yield high revenue for hospitals. That's what they get. So they can't turn. What they did what put us in this situation. They shouldn't be allowed to just escape and just point the finger at us, because that's not fair.
Well, I'm going to revert to my internist days. You know, I'm trained as an internist. And how I would characterize that affliction is selective amnesia, amnestic disorder, NOS. not otherwise specified. You're right. To me, it's frustrating that there is this high level of amnesia about the very situation Downstate has been put in for 30 years, 40 years along the way, right? Then compounded by the severe case of amnesia they had over the fact that a governor made us COVID only, which blew a $100 million hole in our budget, right? Structural, now that's the structural deficit. If COVID had never happened, colleagues, our structural deficit, correct me if I'm wrong, Sean, about $25 million? A little higher, okay, I'll give you 30. It would be a $30 million measly problem, you know? Right? CFO term there. Measly problem, but they compounded it by, you know. So again, I share your frustration. There is a lot of amnestic disorder when it comes to some of the way they have, you know, addressed our challenges in terms of the physical facility. Remember, say again? Yeah, and yeah, we get hammered about Litch too, by the way. And the Litch narrative is interesting because it plays into a little bit about the Community Advisory Board and the recasting, because I had one high-ranking state official who, well, I will keep, you know, anonymous, but he said, Riley, how can you come here asking us for more state support of Downstate when you guys fumbled Litch? I'm telling you what they tell me, you know? And I hear this. You hear it too. So there's, again, some sort of interesting circular logic that, well, you guys fumbled Litch, so we can't give you any more money because you'll fumble that also. You know, that's just the dynamics we're dealing with, you know, all of this. So I just want to be transparent with you about this. So let's go to the Community Advisory Board. I want to salute Dr. George. Dr. George, stand up. You know I was going to pick on you. Stand up, Dr. George. Stand up. You don't know the abuse your colleague has taken as a member of this advisory board, appointed by the governor upon the nomination of Senator Myrie. She'd only been here 3 minutes at Downstate. She trained here, but went away, and we recruited her back to be the chair of Family Community Medicine. Next thing you know, she gets appointed by the governor to the Community Advisory Board. So, you know, she has done an amazing job against some very dicey dynamics, a lot of it political that she had no understanding of because she's been away from New York. But she's done an amazing job, and that's why I want to salute you. I don't want to put you on the spot. I'm not going to call upon you to say anything unless you want to. But she has been excellent, and, you know, just, yeah. Now, in terms of the Community Advisory Board, again, I was away last week, but they had their last meeting, and they kind of laid out in, I'm hearing, in kind of broad outlines 4 possible scenarios. The same, okay, so all of you know. But like I said, the one that is the most curious to me is the one to basically just sort of move things to Kings County, right? Well, look, how much dish money does Kings County get there? Sean, do you know? I mean, if you just had to guesstimate, just based on their size, $900 million. So if Kings County loses $900 million, how is that going to work? How can they afford to even absorb anything, right, if they lose $900 million? So that's, again, sort of the crazy dynamics in play here. So we don't know what's going to ultimately happen. The report is due June 1st. There was one extension granted, correct? The report goes to, doesn't come to me, doesn't go to the chancellor, it goes to the governor. And it's her, she gets the final word in terms of, say again? She can still change her mind. She could accept the report, she could lay it aside, she said, thank you very much, I'm not listening to that, I'm going another way. The governor has the total power over this whole situation. And again, I reminded all of us that a governor of New York is probably one of the most powerful governors in the entire country. So it's really going to be in the governor's hands. Now, remember, she's running for re-election in November. Where does she need to get votes from? Brooklyn. Central Brooklyn. Guess where we are? Central Brooklyn. So there's a lot of political dynamics that are then going to start seeping into this, even more so than what Dr. George has already dealt with. You ain't seen nothing yet, Dr. George. Once we get to, you know, the primaries, the Democratic primary, and then the general election. So, so we're going to be in the news a lot more. You thought we've been in the news for the last year? As long as we got this governor's race going on, it's going to keep popping up because it's going to be a leverage point in the community. Governor, we won't support you if you don't support Downstate or some permutation thereof. So I just want to be plain about the political dynamics there. Any questions about the community advisor? Dr. Visman.
My view is when the $750 million is still available, we should take the money and run because Congress is charged with the $880 billion reduction. And guess where is it going to come from, right? Medicaid in 4 years.
Well, but again, that's what we don't know. You raise a good point. Could the governor pull back that $750 million because she's got a $90 billion hole to fill? Now, it's in that lockbox. Is it capital dollars specifically? And so capital dollars can't be touched in terms of budget? See, that's what I don't know. Mm-hmm. Right, that's right. Because remember, that's $750 million. The way this happens is they sell $750 million worth of bonds and then use the money for construction. And to redo the hospital, redo the clinics, redo the ER. So it's capital money, meaning capital money means you have to touch it. You have to sit in it, touch it, walk into it, walk on it. That's capital money. Operating money is all this other stuff, salaries, support, travel, et cetera, et cetera. So that's the way the state budget is constructed. Just capital when they build roads, bridges, hospitals, stadiums. I'll throw that in too, of course. That's capital money. And then there's operating for salaries and, school aid, higher education, SUNY, CUNY, et cetera. Yes? No. Correct. Right. No, you cannot. You go to jail. I'll tell you. You go to jail for doing that in New York, and some people have gone to jail for doing that, by the way. So that's the difference in terms of the way this is done at the state level, is there's capital and then there's operating. So, but your point is germane. Yeah, they said they parked it or lockboxed it over here, but in times of financial exigency, the governor has extraordinary power to stop capital projects, stop Amtrak, stop, all the things that she wants to do, stop repairing the subways. If the state budget gets really bad, she can pull all that stuff back, right? So again, that's part of the uncertainty and the brace for impact. I want to salute everybody because I think the word I've been getting is that the faculty and UUP in particular have been very good in terms of advancing the hospital, its interest, the need for a better clinical facility for our great faculty to take care of patients. That's come through loud and clear as I move through the city, that the faculty and UUP have really done an excellent job, so I salute all of you. And as you know, I've been somewhat constrained because my boss is the chancellor, right? And so I hope everybody understands that dynamic too. Yes, everybody's got a boss, and so do I. So I had to obviously be constrained. Let's see, Dr. Norton, I think those were the key issues we talked about, right? But let me stop here to see if there's any questions, because I know you got to get on with the rest of your meeting and get through the dreary afternoon weather to get home to your families. But yes. Great point. Yeah, I mean, I tell people all the time, the university side of the enterprise is clicking. Enrollment's up, degree completion's up, all the scores are up in terms of national pass rates of all the exams. We're doing excellent. No issue there. Like I said, the existential threat to the university is the hospital and the unknown course of action that the governor ultimately will agree to with regard to the hospital. Like I said, I made one presentation to the advisory board, and they asked me, what would you do, Riley, if you were governor? And I said it this way: if I were governor for a day, I would build a new patient tower across the street, knock down the old garage, put a new patient tower, build a bridge, renovate the existing emergency room to make it bigger, nicer, better, redo all the clinics. When we move all the patient beds out, the SICU, I see Bob over there, ICU, I got the ICUs in the new patient tower. We get, once we decant stuff from the current building, I'd probably cut the building in half, turn half of it into faculty offices, and the other half into student study space, relaxation, whatever. And we could make a go of it. That's what I've argued. Because we don't have to purchase the land across the street. We already own it. They promised me 5 years ago they'd take that building down. They haven't, right? The old garage. That was what I argued to the committee. Dr. George, you were there. You heard me advance the Riley plan as it then got called, right? Then Dr. Salifu and his buddies took a piece of the Riley plan and presented that as the chair's plan, and he's going to talk to you about that. So I'm not going to steal his thunder. But look, we can't have pride of authorship on this. If we can get to a point where we can get to that $750 million and start to do things that make it better for our patients and for the community and for our faculty and our students, to learn how to take care of patients, et cetera, this could benefit Downstate for a long time.
Thank you very much, Dr. Riley. Thank you, Dr. Riley, for explaining what we don't know. Okay, so as President Riley said, Dr. Salifu, please come up. He's got a few slides he's going to show us about his interaction with the advisory board and the other chairs.
Good afternoon to all of you, and thank you, Dr. Riley, for the support, and our dean. I don't know whether he's around or not, but our dean has also been very, very supportive of the chairs of the College of Medicine. But in reality, the chairs of the College of Medicine, they are actually fighting for everybody, not just the College of Medicine, but for the campus. Because we realize that the survival of all the colleges and schools also depends on the hospital as well. And so the effort is for everybody on behalf of all of us. So I'm going to give a little bit of things that we've been doing as chairs to bring our thoughts together and advance them through the process. One of the things we did was to make sure that we follow the institutional faculty process, which is we deliberate, we come up with decisions, and then we pass it through the faculty senate. Dr. Noreen usually would send whatever we send to him through the executive committee, and usually they would vote in favor of what we are saying, and I think that's a very good process. And then I really want to thank you, Dr. Noreen, for making sure that after the vote, all the letters, we've done 5 statements already, totaling about 50 pages of information. These letters or statements are usually sent to the governor's office, the chancellor's office, and to our president's office, and wide dissemination. So thank you very much for that, for disseminating the information. Next slide. So I'm going to, address 2 issues. One of them is, I should go up there. Okay, I'll just stay here. So I'll talk briefly on the UHD transformation, and then I said a lot in the last meeting. You spent a lot of time, maybe 30 minutes talking about this issue, so I'm going to summarize this part today, but I'm going to spend more time on what we're actually doing locally to actually help the system out. Because sometimes you can complain, but you should also do something to help yourself. And I think that strategy is very important when you are talking to people who are supposed to be helping you. In other words, you are helping yourself, so you can be helped even further. So this is the summary of what we have been talking about in all those 50-plus pages. Our community and our learners need UHD as an autonomous, independent academic tertiary care and teaching hospital physically connected to these colleges and schools. So that's what we want. So obviously this statement has a lot of details. It's embedded, it's cryptic, but it says everything that every one of us in this audience would like to say as well. So these are the two additional summaries. We want a new hospital. We talked a lot about phase renovation based on prior experiences with Nursing Station 82. I was actually the transplant program director when that happened. It was a gut renovation of Nursing Station 82 in 2011. It took about 2 years to get that done. It costed about, the actual project was $6.2 or so million, but by the time they finished, it was $7.3 million. So based on that, but that was 2013, right? And it's now 2025. So you assume that there's inflation and all that stuff. So we sort of purged any inflation to around $20 million per floor in terms of renovation. So in the initial proposal to have $300 million allocated to Downstate in capital funding, we thought that the $300 million was reasonable to actually do what we call the phased renovation. Renovate one floor at a time, budgeting $20 million per floor, and hopefully do as much floors as you can to get the place revitalized. But then the plan changed. The governor came out with another announcement saying that the number has changed from $300 million to $750 million. So we had to present a revised proposal. And this is the revised proposal, actually. The revised proposal called for a 250-bed hospital, bed tower. And the rationale is very simple. There are times the hospital has a census of 180 patients, right? And most hospitals would staff 80% capacity. You don't really want to staff 100% because you'll never be able to take the next patient. So assume the 80% is the 180 beds, then your 100% is 220 beds. That's it, it's simple mathematics. So we actually need a 220-bed hospital. But then if you have, emergencies like the pandemic and all that stuff, you're really constrained. So we added 30 more beds and that's basically one floor. 30 beds is equal to just one floor of beds so that we can absorb surges when surges happen. That's the rationale for a 250-bed hospital. And I think it's very reasonable. That is the current state. The current state is that as of today, for instance, I think we had 170 patients. And there were days we had 180 patients. So it fluctuates. Some days 160 patients. So, but if you take the upper number of what we actually have on a daily basis, 180 patients, and then you add it 100% to that, that's 220 beds. So that's the rationale for that proposal. And it has to be a tertiary care academic medical center, which means that we want to be the hospital that provides the complex surgery to patients in Brooklyn, because they are leaving to Manhattan for those same reasons, right? It's very easy to manage the usual stuff, but when it comes to complex surgery, we are really not, staffed to do that right now. We used to have that. When I was a resident, this hospital was booming with everything. Everything, I mean everything. Surgery had so many residents, so many fellowships, and so on and so forth. We had cardiac surgery, even not just a surgery, but we had a cardiac surgery fellowship as well. Vascular surgery fellowship. So many fellowships that were going on at the time in surgery. But without complex surgery, what we are basically doing is we get the patient's worth maybe, $10,000. When we transfer the patient to go and get their complex surgery, we are basically donating that hospital $100,000. That's what we're doing. So we have to prevent that. We have to prevent that by building the complex surgery at Downstate. That has to do with the capital funding, because to design a building, you have to design it such that it can provide those services. So if you design the building just some ordinary flat, two-dimensional building, and it can't provide those services, we are back to square one again. So the design has to also take into consideration the fact that we want to be able to provide complex surgery in this building. The second one is keep the facility, the old facility, intact while the new building is being constructed. That makes logic. And the reason we wanted to make this as a separate ask is because there is this, you heard the president already, there was this idea that Downstate could be squeezed into some wing at Kings County Hospital. That's almost impossible. The president has already discussed that and explained that. It's not possible. So we wanted to make that as clear as possible, that we don't want to be relocated to another facility while the new building is being built. Okay. Now, there are, a number of rationale around that. We don't want to interrupt the services. Services are very, very difficult. Clinical services are very, very difficult to rebuild once you lose them. It's really very hard. For instance, when we had the cardiac surgery, we lost cardiac surgery in 2019. And then in 2020, when Dr. Berger came and we had conversations, how can we rebuild this program? He said it was going to cost $50 million to rebuild at that time. So almost immediately, there's a disadvantage, you see? So it is probably better to keep some of the programs going, and then you can build upon them. But once the program goes away, it's really very hard to get the program back. And of course, in preparation to move into a new facility, we have to do certain things, and I'm going to discuss those certain things that we have to do. We have to improve the efficiency of the hospital, how the hospital is functioning, phone calls, who is answering them, making sure that people have access to the physicians, the patients have access to the clinics and all that stuff. And then once we have a better, environment of operating the hospital, and we're moving to a new hospital, then you have better outcomes in that scenario, compared to we just tie our hands behind our backs, wait for a new hospital to come in, and we have to go into that new hospital and do things new. That doesn't work. And then, as the president said, the old building can now be repurposed. Whatever that plan was, we weren't really involved in that, but we knew that the old building can be used for other things in terms of services. And the third one was the clinical services. These clinical services we think are very, very important. The first part talks about the preventative and primary care services. Obviously, you all know about that. Wellness and diabetes, and this community, myself and Dr. McFarland, we did a study in the early 2000s. Just walking around this area, you interview people, you take their blood and do an A1C, 33% of our population has undiagnosed diabetes, or diabetes, the whole thing. Now, if you look at nationally, the number is about 10%. So there's a very, very high risk of diabetes and hypertension. I did another one in hypertension, it was 34%. It's very, very high. So we need something around wellness and diabetes care. We also need something around cancer screening. Of course, we have cancer screening, but we're talking about something that triages and has a strategy to build programs around all the cancer-providing services, which means internal medicine, oncology, general surgery, all the cancers in general surgery, ENT, orthopedics, all the other services that provide cancer care. And of course, maternal and infant care is very important. We are the only, I think we're the second regional perinatal center in Brooklyn. This is something that can be enhanced if we had the right resources. And then mental health screening, evaluation, management is also very important because, after COVID, there was just a lot of trauma in our communities and it needed a lot of help. And so if we had programs within the new system that addresses these issues, we can actually invite new people to come in. In other words, we have all these buildings, right? These new buildings are coming up, and all of you, it's not like a secret. Whatever block you walk around this, hospital, you're going to see new buildings coming up. If you don't have these four things, it's very hard. It's really very hard to attract those people to come into this building. Some of them would need these, wellness programs. They would need these mental health screening programs. They would need these maternal programs. They would need the cancer screening programs. They just need to be healthy, not to be sick, right? So we have to focus on keeping a healthy community. And then if they get sick, we have a chance to take care of them in our new hospital. So this is really, really very important, to attract new volume into our system. And then the rest is now providing the high complex medical services, medical and surgical services, including transplantation services. So this is, we attended all the advisory board hearings Dr. George, thank you for representing both sides. You know, she's a chair and she's also on the advisory board, so that's a very good thing for us. But we attended the 4 and we made presentations and submitted statements. In addition, we had the opportunity to actually meet with the advisory board one-on-one. They actually met with the chairs only. We had 1 hour with them. They asked questions and we were able to answer them. If there is time, I'll be happy to tell you what they were asking. But in the end, this is what they're talking about. This is the last advisory board meeting that happened. Obviously, the 250-bed hospital, there's a lot of traction around it in terms of ideas. The Brooklyn for Downstate group actually has models around this idea. We actually support them. We wrote an email, the chair said we actually agree with the idea and the model that they were proposing. So the whole idea was to make sure that we are not talking against each other. We are talking with one language. That is the chair's plan, the union plan, the UUP plan, and hopefully the Brooklyn for Downstate plan is all consistent. So I think this plan reflects all the things that we've been talking about around the number of beds for the hospital. So it's a new hospital tower. This is what they are talking about. So you basically build a new 250-bed tower and then address the mechanical issues of the hospital and then rehab the first 3 floors for shorter part of hospital. So there'll be just a little bit of rehab, that's renovation of some parts of the hospital on the first 3 floors. The outpatient will be, enhance the ED in the current location and additional space for step-down services or observation services attached to ED. And of course, the clinical services. So this one basically talks about our plan and then the Brooklyn for Downstate plan. The union actually supports the Brooklyn for Downstate plan as well. This plan was, if you look at the text that was circulated, it's actually not from UUP. I just want to make that clear. It's from Brooklyn for Downstate, but the union supports that. I just want to make that clear. The second plan was a new advanced ambulatory surgery center. This was something that was, I was lucky, Dr. Riley, to be part of your first team to come up with this plan. That was in 2017. It was called a short-term strategic assessment, which we submitted a report to the president at the time. And basically, the current chair's plan reflects that plan, actually. What we submitted in 2017 is what we were trying to reflect, because at the time, even the idea of having high-level surgical services was what Dr. Riley was pushing for at that time. It just didn't happen, but that was what he was pushing for. So in this plan that we are submitting with that table that I gave you in the previous slides, that is the plan, actually. So in this scenario, there will be a new ambulatory surgery center, which is very good, and a new hospital tower and limited hospital rehab. So they will do less with renovating the building and spend more of the money creating this ASC, the ACS, Ambulatory Surgical Center, and the new hospital tower. But it's almost similar to scenario number 1. The scenario is basically a smaller version of scenario number 1. That's the way I see it. Because instead of having 250 beds, you have 100 to 200 beds. But knowing who we are, we're not going to be taking the 100, we're going to be taking the 200, I guess, in this scenario, right? So this and that are almost about the same, in my opinion. But these are completely different. The last two are completely different. This scenario is a partial hospital rehab, right? Which means that, we would do some limited renovation of some parts of the hospital and get a new ambulatory surgical center, an ASC. This is not properly written. It's supposed to be an ambulatory care center, with or without an ambulatory surgical center. So this is an ambulatory care center, not surgery center. So in this scenario, because the partial rehab, you remember the president has said this in other meetings, the hospital needs to come up to code if you're going to do renovation. So we have to spend a lot of money doing the code thing and all that stuff to bring this hospital back to up to where it's supposed to be. So with that plan, we may get 45, rooms that are going to be renovated. It's very small. The impact is very, very small, and I don't think this is a great idea at all. But because of the ambulatory surgical center idea, or the ambulatory care center idea, is quite attractive. And then the last one is a partial hospital rehab, that is, renovate the hospital, and then you get a new ambulatory surgical center, plus varying levels of collaboration with health and hospitals. This was not clarified, but if it is clinical collaboration, then we are not strictly opposed to a clinical collaboration. And the reason is because if you look at cardiology as an example, patients who come to Kings County Hospital because they have a heart problem, just guess what happens to them when we make the diagnosis. By the way, the Downstate doctors are making the diagnosis. We are the ones doing the calls at Kings County Hospital. I was on call over the weekend, just this past weekend. I worked 70% at the Kings County Hospital, 30% of them, because there was so much volume at Kings County Hospital. So that is what the Downstate faculty are doing at Kings County Hospital when they're on call. So when the patient then lands at Kings County Hospital and the patient has a heart problem, guess what happens? We, the Downstate doctors, make the diagnosis, but the patient ends up at Bellevue. That doesn't serve any purpose. It just doesn't serve any purpose. Number one, you're displacing the patient, displacing the family members, and then number two, you don't provide any value for the learning. There's really no value for my fellow to see the patient ends up at Bellevue, especially for cardiology. Patient ends up, gets a cardiac catheterization, the fellow benefits from Bellevue, who had nothing to do with this patient. The patient goes for cardiac surgery, the fellow there benefits from, the learners all benefit from that system, but we generated the patient. So none of this stuff makes sense. If we had a system where we the Downstate doctors are taking care of this same patient at Kings County Hospital, we are unable to provide the care at Kings County Hospital, and then we had this system relationship where there's a clinical collaboration to send the patient to Downstate for their cardiac catheterization, and we do a lot of complex cardiac stuff. Very rarely, do we, send the patient out. Then 90% of the time, we will be able to take care of the patient, keep the patient local, keep care close, right? Isn't that our campaign? Keep care close. So that is what needs to happen. So we are not entirely opposed to a clinical collaboration that serves the needs of the patient and keeps the patient locally for care that is available locally. But in terms of infrastructure, this is the least of the options for us. So I just wanted to bring that to your attention. Now, the CHAIRS plan, like I said, is still number one. You ask for more, and we see what happens. So that was our strategy. We'll ask for what is optimal, and then the rest is subject to, a little bit negotiable. But we don't think we should go anywhere below item number 2 from the CHAIRS perspective. Okay, so that is the work that we've been doing on the transformation. Now I'm going to tell you what we've been doing to say we are not just sitting idle and asking for manners to fall from heavens. We've actually been working towards improving the system. We met on June 13th, 2024, and then we came up with what we call the short-term volume action plan. And we dubbed it 365 now. In other words, let's get something done before the next cycle, 365 days, so that when the advisory board hears that we are also trying our best while complaining, they will take that into consideration as well. We used the PDCA model, which means you should plan something, perform something, monitor something, and then try to do a performance improvement to improve what you're doing. That was the model that we used, and the whole goal was to improve access to care to patients. In other words, we didn't want a patient wanting to access Downstate services and couldn't get the service. Improve access to the physicians. We didn't want a community physician wanting to refer a patient to a Downstate physician couldn't do that. And build a more efficient system that would ultimately attract volume. And if we did those two things right, then the volume from the faculty practice side and also the hospital should improve eventually. So these are the 8 points. The phone system, we wanted to make sure that the phone systems are working properly. We had work groups, and it was just a lot of meetings and redesigning and all that stuff. We eventually piloted a phone system in December of 2024, using medicine as an example, and we are going to expand to surgery and other services. But now we have a centralized phone system for UPB that is now going to expand, which didn't exist before. And that phone system is really very effective. I haven't heard of many missed calls in the last week or so. Patients are calling, somebody is there to answer the phone. We have a phone directory. We have agents. Agents, if the phone call comes through and one agent is busy, the phone automatically rolls to the next agent and so on and so forth. And so we are really very impressed about that effort. It's very successful. And anything that you see in the 8-point plan that is green, it means we are really happy with ourselves. That's what it means. Okay. The second one is open schedule system. Open schedule is a technique used to improve the efficiency of a doctor without necessarily adding more time to the doctor. So doctor comes, let's say you are scheduled from 8 to 12 to see patients. Open schedule means if you could come at 7:45 and leave at 12:45, you could actually get 2 more patients seen in that open schedule period. And just 2 patients alone per week, and everybody's doing that, it's a lot of patients. So we use the open schedule technique to improve how patients actually access the system so that nobody's waiting too long. Now, one of the barriers in the past was insurance. Patients call to make an appointment and say, what is your insurance? We thought that was the main problem that was preventing patients from making appointments and getting to see the doctors. So we eliminated that. A patient who calls now to our faculty practice and to UHD, we would not ask your insurance. We will make the appointment first. When you come in, we'll figure it out. That's what we're doing right now, so that we can have access to patients. Patients can come in. And you know what? Everybody eventually gets insurance. We have a mechanism to do that. There's a process called the patient access within the hospital system. They know this insurance business. They sit with the patient, they talk to the patient, they find the information, they guide the patient, and eventually patient can be triaged into insurance. So we eliminated the insurance barriers. And because of that, everything's really improved. And I'm going to show you examples to that. Access to evening hours, Saturday clinics, and so on and so forth. We're able to get a lot of the doctors to open up evening hours beyond 5 p.m. and also Saturday clinics to have more access to patients, and that was also done. So it's green. The website, you remember the president, thank you, Dr. Riley, President Riley, for committing $500,000 to a campaign. It's called the Keep Care Close campaign. It was started in October or September last year. And so I'm sure you've seen a lot of things going around in emails and so on and so forth. But it's come along very well. A lot of posters, flyers. They've been able to text hundreds of thousands of patients, I understand, in terms of telling them about the services at Downstate, and it's so good to have. Part of that was also to update the website. The website, we met with IT, and it's really amazing. Without money whatsoever, we're able to restructure the website. If you go to the website, and I like everybody, okay, if you went to the website before this was done, you saw a basic science lab on the front page of Downstate, which is okay, because we all love the science. But it wasn't patient-friendly. We changed that. Now, if you go to the website at Downstate, you see, patients and faculty interacting. It's more patient-friendly. And now you can make an appointment directly from the website, which is very, very impressive. So this is also very done with the faculty was very cooperative. We took new faculty profiles. Everybody now looks nice and smart. If you go to the picture side, you see nice pictures of the faculty, and their phone numbers and even emails are present. Stop the leakage was number 5. This is still in progress. That's why it's yellow. We hope that when we achieve everything, we would greatly reduce the number of patients leaving our system into other systems. The operating room, we thought, is important to optimize because surgeons in the community would love to use our OR if it was easy for them to use the OR. In other words, if I want to do my surgery at 8 o'clock in the morning, I don't want to come here at 7:30 and then finally get out at 10. I don't want to do that. And hospitals that are able to accommodate the community physicians, their time, actually do very well because you want to bring more patients. So we've been doing a lot of work around this. It's improving a lot. And I think that over time, we're going to achieve a lot from that. The next one is the referral system. We've done 3 activities to improve the referral system. One of them is called Flare Health. Flare Health is a program. I'm going to show you some slides. It's a program that is almost like an app. The doctors will sign on to the app, and any doctor can refer a patient to you, independent of whatever electronic medical record system they are using. Because in the past, one is using Epic, another one is using HealthBridge, that's the one we're using at the UHD. Another person is using Athena, Faculty Practice Cider, and so on. So many electronic medical record systems. But with Flare Health, we're able now to just equalize the playing field. Anybody on Flare Health can refer to another person on Flare Health, and everything is nice and smooth. We also came up with a radiology portal. Radiology, doctors want to be able to request and review reports and not necessarily be on campus. We've been able to achieve this as well. Referrals from the ED, patients who come to the ED and need to see a doctor within 72 hours, it was very, very hard to do that. Now, when a patient leaves the ED, within 72 hours, they can actually see a doctor at Downstate. And this is all new stuff. And we also, the last one, we wanted to make sure that if any hospital wanted to refer a patient to Downstate, they should, I can't send a patient to Downstate. We wanted to make sure the process is very clean and it's clean. We worked on that, we came up with a plan to do that, and the plan is actually working, including Kings County Hospital. So this is the referral app. Doctors are in there. Just click Salifu and boom, I have a patient and I respond, thank you, something like that. Thank you, right? And then within a couple of days, the patient is scheduled and the response goes to the doctor in the community. So now we and the doctors in the community, we are all in sync at this point. This is when we started. Now we're up to 1,500 referrals coming into our system from this referral app. And they are coming from different practices. So this tells me that the community, they really want to refer patients to Downstate. It's just that we have to make it easy for them to refer patients to Downstate. So hopefully with this referral app and other activities, we should be able to achieve that. This is an example of open schedule. The red means that we were able to open the doctor's schedule a little bit before and a little bit after, and bang, they were able to absorb a lot more patients. This is an open schedule example for surgery. We worked with surgery to open the schedule very nicely. And now, in surgery, you can see a patient the same day in surgery. So this is very good. And these are the times. Now, all this used to be like 2 months, 3 months, now it's in weeks, because we just expanded the schedule. Like, we ballooned the whole thing, and now we're able to absorb everybody. So most of the services are not taking patients, typically within 1 or 2 weeks. And same thing, this is additional data. It's within one, the highest is like 6 weeks. The peds dermatology is a little problematic because there's only one doctor. But all the other services are really very good in terms of the open access. These are the surgical programs. You can see general surgery, orthopedics, ophthalmology, ENT, and these are the surgical services. Very nice. You want to see a surgeon, you can see a surgeon within a very nice time frame. This is the referrals from the ED. When a patient comes to the emergency room, the ED doctor is discharging the patient, and they want the patient to be seen in 72 hours. Before, it was very hard. When we implemented the program, every single service is involved. It's less than 1 year, and 1,800 referrals were made successfully with no problem in the app. So we're very happy with that. It needs to be tweaked a little bit more, but we are very happy with the result that we're getting so far. So in summary, I think that the volume action plan was designed as a supplement to what we're doing with the advisory board. We think that we've made a lot of inroads. We believe that we've improved access to care. We've improved access to the physicians. We are building a more efficient system that will allow the volume to increase over time. But we still need to do a little bit more in terms of monitoring the process to make sure that people don't fall behind what we have already implemented. So thank you, Dr. Noreen and the Faculty Senate for the invitation. Thank you.
that just laid out, so we're worried about that. We're hearing that advisory councils are not meeting. They started up again finally, but just because the advisory councils pass recommendations on to the institute director to fund a grant doesn't mean that it's necessarily going to be funded, because the final authority in terms of who funds the grant, it rests with the NIH director. And the new director just has only been there 3 weeks, so we're worried about that. So there is broad potential bracing for impact on the research side. I was one of 1,800 members of the National Academy of Medicine who signed an open letter that really highlighted the problems. Marlene, where was Marlene? She was here. Oh, you weren't you here? You moved on me. Yeah, I'm about to say, I was looking for you earlier. Yeah, you too, in terms of research. Great work you're doing. But I was part of the 1,800 members of the National Academies of both science and medicine and engineering that signed an open letter that really raised the problem that we have as a nation if we were to gut the science agencies in terms of the health of the United States, but indeed the world. So we're worried about the research impacts too, right, David? You want to say anything?
Well, we've been trying to keep our local research community up to date and letting everybody know that we're on top of it. There's a weekly meeting that I participate in with the the Central Research Foundation, who often, along with their council and SUNY council. It's hard to keep up with all the negative things that are coming out of Washington. In the past 2 weeks, there have been 2 or 3 new ones, including one that we're very concerned about that came out 2 weeks ago today, which is a notice from the NIH that says that, essentially what it says is that institutions, if you accept a grant, you accept the notice of award, whether it's a new grant or a continuing, non-competing continual renewal that we have to do every year, you are essentially saying that your institution does not have any DEI programs that are, and this is where I think we're okay, in violation of federal law. And it's not research, it's DEI programs, it's any DEI programs. Unfortunately, well, the whole thing is unfortunate, but unfortunately, SUNY Council has not yet weighed in on exactly how we deal with that. So we're in a bit of a limbo for 2 weeks running, but we're trying to stay on top of everything and do our best to guide us all through this.
On that last point, the Chancellor and the SUNY Board have instructed all SUNY presidents not to engage in premature anticipatory compliance with the federal government. So what that means is, basically, is SUNY expects to be sued very shortly. You know, they've spent the first few months going after Harvard and Columbia, but they're coming for the University of California and the State University of New York, the 2 biggest systems in the country, the 2 biggest blue estates in the country, 2 states that the President of the United States does not like, New York and California. So we're bracing for SUNY to be called on the carpet at some point. I've not changed a thing. I've sent a directive down to our deans. Do not change any titles. Do not stop anything until I am instructed by the governor, the attorney general, or the SUNY board or the chancellor. So we're not changing anything. But I am mindful of the fact there may come a time when the governor tells us or the attorney general says we have to stop doing X and Y. But until that time, we're continuing to do X and Y.
Interestingly, I was on a special study section a couple of weeks ago on xenotransplantation. And you may know, it's obviously in the newspaper about NYU. They have a program there. And the program evaluation got postponed by about 3 weeks because of all the turmoil in Washington. But we did meet a couple of weeks ago. I wrote my critiques and so forth, and we finished our job. But the NIH person, he doesn't have a clue as to whether they'll actually be funded at this point in time. So, and this is a program that's been going on since 1990. Okay, so without further, what do you? Huh? Yes. Oh, Joanne's next? Oh, okay. Okay, so we have two subcommittee reports. Joanne is going to report on her committee, the Committee on Nominations and Elections, and she's going to present the slate of nominees.
Thank you, Dr. Noren. I just want to see, were we able to get a slide? If not, I'll just read the names. Move out of the lights, my goodness. No? Oh, here we go. I should use the podium.
You have to hold it.
Does it not, okay. Great. All right. That is not, no, that's Dr. Perkins' slides. I do not, is it? I apologize. I don't know either.
Can we get the next slides?
It was just one slide from a chart related to all of our nominees. Okay. I apologize for the delay. No.
Yeah,
Yeah? Okay, sure. That's good. Thank you, Dr. Perkins. I apologize. Keystone Cops here. Thank you. I apologize. You need your pen? Thank you.
So we'll just reverse the order. Okay, so we're about to have elections, and as part of that election, on the ballot, there are going to be some bylaws amendments. So you may remember that in March of 2023, we had a really big revamping of the bylaws, and that passed. This is small stuff compared to that. So you can see there the bylaws subcommittee names, and it was really great because we had representation from all the schools and colleges. Everybody participated. I've divided into three main groups here, the proposed bylaws amendments. The first is to have a past presiding officer, which we don't have now on the executive committee. The second is some rules for special elections, and the third is just some minor election clarifications. So these amendments have been approved to show up on your ballot by the executive committee, but that ballot will go out to the entire membership of the assembly, and it's going to take a 2/3 majority of those voting to pass the amendments. All of these amendments are additional language, not replacement language. So the first is to create the position of past presiding officer. So that main purpose is to provide institutional memory and advice on the executive committee. And we decided that it should be a non-voting position. So here's the actual language. So it's going to show up in Article 5, and it's just going to be added to Article 5. The immediate past presiding officer shall be a non-voting member of the executive committee unless they have voting rights by virtue of another position they hold in the executive committee. And then that second one, the immediate past presiding officers shall preside at meetings in the event that the presiding officer, elect, and secretary are all absent. So you'll be able to vote yes or no on that when it shows up on the ballot. The second one is rules for special elections, and the main purpose here is that the bylaws in their current state refer to special elections to fill vacated positions, but don't have any rules for special elections. So that leaves us in the position of, does our Nominations and Elections Committee make the rules up, or do we have to follow the rules for a regular election? So we decided we needed rules in the bylaws. And we decided that those rules should offer clarity, transparency, and flexibility. So this would be added then to Article 11. When a vacancy of a senator, alternate senator, or presiding officer elect occurs, a special election shall be held as soon as is practicable to fill the vacated positions. If the vacancy occurs during the period of January to April, the election to fill the vacant position may occur with the regular election in April or early May, or. So it can happen with the regular election or separately. So number 2, the nomination procedure for a special election may proceed as described for a regular election or may use the alternate procedure in 3, which is on the next slide. All nominations must be valid within the rules outlined in these bylaws. And here, the alternate procedure, it's very similar to the regular procedure. It just gives you a little more flexibility for a special election when there might be only one position up. So number 1, the Committee of Nominations and Elections shall prepare a slate of candidates attempting to nominate at least 2 people for each vacant position. And 2, the slate of candidates shall be announced to all members via email, along with a call for further nominations from the membership. So the way this is different is now we announce the slate actually in this meeting here and get a call of additional nominations from the floor. So this would just allow us to do that process via email and electronic means. Number 3, at the end of 2 weeks, the resulting slate of candidates will be announced to all members via email. A period of 4 to 8 hours after the slate is announced will be used to ensure that the slate reflects all the valid nominations that occurred. So we added this because we once had a situation where somebody had nominated somebody and somehow they didn't end up on the ballot. So by putting this 48 hours in there, we can make sure that never happens again. And then after the 48 hours as have elapsed, the slate of candidates will be declared final and the ballots prepared. And then from that point on, the election procedure would follow the same procedure as that of a regular election. Any questions for me so far? So those are the big 2. The rest of it is small stuff we found when we were looking at those 2. So these are the minor things. Just to add that persons elected in a special election to fill a vacant position would take office as soon as the election results are announced. So that would show up in Article 11. Also in Article 11, we just added this point. It's been happening anyway, but you can see that language in blue that makes perfect sense will just be added to the bylaws. And then the next one's even smaller, to add the word ballots here under the Article 13, the Committee of Nominations and Elections. So those things will show up on your ballot for a yes or no from you, and we need a 2/3 majority of those voting to add those things to the bylaws. So does anybody have any questions about what I just presented? Any comments you want to make to everyone sitting here about them? No? Okay, so we'll let Joanne come up then.
No questions for you because you did a great job.
Okay.
You going to use that? Okay.
Were you able to locate the slide for Joanne?
That the Nominations Committee is the same as the Bylaws Committee. So I'd like to thank John Kuby, Janet Rosenbaum, Bridget Desport, and as well as Mark Stewart, who is actually wound up to be a nominee, so has recused himself from the work of the committee. Oops. Okay, so back in April, actually the work of the Nominations Committee began in January. We've been working in collaboration with the Executive Committee, and you might have seen a few emails from me related to a call for nominations. We did that in April, early April, and I'm very, very pleased to say that we had a very robust response. And we have a very, very talented group of nominees, 17 in all, I believe it is, 15 in all nominees. So again, a very talented, okay, it's not up there. Oh, it's going to be up there in a minute so that you can see in all of the nominees. I'm pleased to say, as again, that we had many responses, all very talented people. I also want to say that all of the schools and the hospital are represented here. Not that we vote from 4 different positions from different schools, but this lets you know that we have a beautiful array of candidates from all of the schools and the hospital. let's see, what else did I want to say about this, is that we're sharing this information with you today, and we also, at the end of this presentation, we will accept any nominations from the floor, if there are additional nominees that anyone would like to put forward. Yes. Thank you for saying that. Okay, so we actually have 5 positions, or 6 positions. We have 1 presiding officer position. We have 1 secretary position. We have 2 senator positions that are vacant. So I believe the 7 candidates will be for 2 of the senator positions. And we have 2 alternate senator positions, and we have 3 nominees. So the candidates who receive the highest number of votes will be appointed to those positions. So does anyone have any questions about the ballot as presented?
Does anyone want to make any new nominations?
Yes. Okay, that's wonderful.
Thank you.
We will add her to the list and look forward to receiving her materials so that we can continue to work. I'd also like to thank Alethea Aline, who we've been working with together to get the Vote Now nomination together. So once we get, if there are no additional candidates that are put forward, we will probably be ready to vote on, launch the ballot via Vote Now probably by next Monday. But we have to give our candidate enough time, sufficient time to be able to add that to Vote Now. Okay?
So we officially have to close the nominations now? Is that correct, Catherine? Yeah. Okay, the nominations are closed, and you will be receiving... Go right ahead. Go ahead.
So will the voters choose one candidate for senator, or will they choose 2? Each person will he or she vote for 2 people for the senator position? Or
Yes.
2?
Right.
Each person.
So you'll be receiving a ballot to vote on the candidates and also to vote on the bylaws. Approximately 2 weeks from now? I think that's right.
Okay,
Okay,
that's my.
thank you so much.
That concludes my report, so thank you very much.
Okay, so I'm just going to open up the floor for old business. Is there any old business today? No? Okay. Any new business? No? Okay. Then I'll entertain a motion to adjourn. So moved. See, I gotta put this up. Nice job. Nice job.
Scary, huh?